Moving right along down the respiratory tract, we're in part 6, and we are going to discuss a variety of conditions that are a spectrum of croup. LTB and epiglottitis are the worst form of croup. So epiglottitis is inflammation of the epiglottis. It usually is occurring in our preschool and our early school age children. It used to be far more common before the Haemophilus influenza B vaccine was implemented. But remember that there is a large pocket of the pediatric population whose parents decline immunizations, and so we're still going to see this illness. What epiglottitis, or how it differentiates from laryngotracheobronchitis or sudden onset of spasmodic croup, is that this is a very sudden onset and it progresses rapidly to respiratory decline, and if not treated, can lead to respiratory failure. So you can see on this picture where the epiglottis is. When it gets inflamed, it becomes cherry red and very swollen, and it can completely obstruct the airway. So what we assess, and you need to know these, are the 4 Ds. Is this child drooling? Do they have dysphagia? Which is really why they're drooling, because they can't handle their own secretions. They also have dysphonia, which means that they can't really talk, or they have a very hoarse voice and it's stressed. And are they in distress? And you should recognize that this child is in distress, because this child will not want to lay down. They have a stridor. Their voice is going to be muffled. Of course, they're going to complain of a sore throat. They'll have a high fever. Between 102 to 104 is not unusual. And remember, this was a very rapid onset illness. So this child is going to look toxic. In other words, they're sick, very sick. As they become more hypoxic, or they're having difficulty in getting air in and out, they become agitated, and then they become fatigued, and they become more and more lethargic. As you are watching this progression, be prepared to assist with intubation, because this child may go into respiratory arrest. You'll also put on a pulse ox, and you'll notice that there's progressive cyanosis and hypoxia. So here's a picture of a child. It's a preschooler. Now, normally this kid would be absolutely fighting you, but he is just sitting there with his mouth wide open and just looking with an expression on his face of, I am not long for this world. So he'd be drooling. His chin is pushed forward so that he can extend the airway. When you look at the x-ray on the right, where the arrow is what we call the thumb sign, because the epiglottis becomes so edematous that it looks like a big thumb is compressing against the airway. So how do we treat it? Well, this is a medical emergency. You need to keep this child as calm as possible. Do not make this child lie down. If he wants to sit on his mom or dad's lap, let him. We'll do everything that we can while they're still sitting on the parent's lap. We keep this child NPO because he cannot handle his own secretions, and there's going to be an increased risk of aspiration. And this is going to include administration of antipyretics. So if the child has a fever, we're going to give Tylenol via the rectal route. If the child needs oxygen and they start fussing at us because they don't want to have on the nasal cannula or the mask, what we do is we give it what we call blow-by. We'll have the parents hold an accordion-type tube, and it's humidified, and they hold it near to the child. That's what we call blow-by. We're going to transfer this child usually to the ICU, or if they don't have an ICU and the child needs to be intubated, he may have to go to the OR and end up having an emergency trach. We also administer antibiotics IV. Your job as the nurse is to keep your eyes on this patient. Observe them very closely for respiratory distress. they will be admitted to the hospital for up to a week. If we have to intubate them, they are usually intubated for about 48 hours because it's going to take that long for the swelling to reduce. So when you are on your units, make sure you know where the crash cart is because you might be the one who has to run and get it. When we think about emergency intubation equipment, you're going to need the laryngoscope, making sure that the light actually turns on when it's opened up, an endotracheal tube, and we're going to need suction equipment as well as oxygen. So always stand by, being ready to assist with intubation. Laryngotracheobronchitis involves the larynx, the trachea, as well as the bronchi. We're going to see this in our younger children, our 3-month-old all the way into preschool. This is considered a viral condition. It's very rare that it's due to a bacteria. It has a more gradual onset in that this child is going to initially have a history of a URI, and now it's gotten worse. And typically, the onset of the croupiness is going to occur after the child's gone to bed. So they have a harsh, barky cough. They may have a hoarse voice, and you'll hear stridor. As respiratory distress increases, they're going to become more tachypnic and tachycardic. If they become pale and eventually cyanotic, this is a very late sign, and also be prepared to perform emergency interventions. These children may or may not have a fever, and we'll give antipyretics. And then as they become more and more toxic, they're more irritable and agitated. So here are some pictures. On the left is a nice normal airway, very wide. But then look at the one on the right. And here we have just below the glottis, it's very narrow. And that's what contributes to the barky cough and the stridor when this child is trying to breathe. And here's an excellent example of severe sternal retractions. And if you look at the child's nares, you see how broad they are. That's because even though he's having retractions to pull in, he's having to suck air in so hard that his nares are flared. And so we call that nasal flaring. This is another condition where we want to keep this child calm, because crying is going to increase the possibility of obstruction of the airway. We provide humidity. If they're in the hospital, once again, we're going to give them blow-by cool mist. Some may be put in a mist tent, but this is going to be more for the real young kid where we can put them completely underneath the tent. The bigger kids, our tents aren't big enough. If the child is not sick enough to be admitted, then we're going to tell the parents to take them into the bathroom. They turn on the shower, close the bathroom door, and get the entire bathroom steamed up. And that way they are breathing in humidified air. If admitted, we're going to give them hydration via intravenous fluids. If they're going home, then they need to push as much clear fluids as possible. In the ER, in the ICU, we will give them racemic epinephrine, which is epinephrine that is nebulized. And this would be used if they have a severe stridor and obstruction. We give oxygen as needed based on their pulse ox. And we will give them prednisone 1 milligram per kilo once daily if it's oral, and we'll give them Solumedrol if it's IV. Tylenol or Motrin is given for fever. If there isn't much of an obstruction, they can go ahead and take this orally. If it's a big obstruction, then we're going to give that rectal. We avoid sedating these kids because generally they do not need to be intubated. And then antibiotics are not needed because this is typically a viral condition. Here's a picture of how the parents can provide humidified mist using a humidifier. And they just put a towel over the child and they turn the humidifier on. One of the things you want to talk to the parents about is making sure that once they're finished using it, that they completely clean it out, they wash off the filters, because if they don't clean and dry it, then mold and mildews will develop inside the equipment, and then the next time when they need it and they're in a hurry, they're not going to be looking at this, and the child is inhaling these molds. So spasmodic croup hits our little ones, 1 to 3-year-olds. I've seen it also in the young school age. Once again, it's sudden onset at night. They have an inspiratory stridor, a harsh cough, and their voice is hoarse, and they have a mild form of dyspnea. They become agitated because they feel like they can't breathe. They hear the sound that they're making, and this makes them afraid. Sometimes they can become cyanotic, but this is not the usual case. If they are cyanotic, this is a child who will be admitted. At home, we want the parents to keep them as calm as possible, provide the humidity, similar to the other problems, and then give them fluids, and this will self-resolve. If we admit them, we're going to give them oxygen that's humidified as needed. We're going to elevate the head of their bed, and we can provide blow-by humidification as the child is sleeping. And this ends this section of the ENT disorders.